Hi, everyone. Today, I'm extremely excited to be speaking with Dr. Shawn Tassone. Dr. Tassone is also known as America's holistic gynecologist. He is board certified in obstetrics and gynecology and by the American Board of Integrative Medicine. He holds a medical degree in addition to a PhD in mind-body medicine. Dr. Tassone is a highly regarded patient advocate. His work includes studies and publications on spirituality in medical care, whole foods to heal the human body, and integrative medicine. Dr. Tassone works as an instructor for medical residents and students at the University of Arizona and the University of Oklahoma Health Sciences Center. He even teaches integrative medicine at Arizona State University. As an integrative health practitioner, Dr. Tassone believes that you should have an active role in your care. He'll not only treat a certain symptom, but also your body as a whole. This method can help with prevention of chronic illnesses as well as maintenance so your body can heal itself. So, Shawn, thank you so much for joining me today, and I appreciate your time.
Hey, thanks for having me on.
Awesome. So I want to start by just talking about your journey into OBGYN and more specifically into functional medicine. That's a very interesting combination, and so I'm curious how that came about.
So it's kind of there's a long story, there's a short story. The short story is basically, when we're in medical school and we're planning our electives for fourth year, trying to figure out what we want to do. I thought initially I wanted to do internal medicine. I liked the diagnostic aspects of figuring out what was wrong, but then I also found that I also liked fixing the problem in the sense of, if there was an issue, and I think that's the surgical kind of mentality. And I also really liked the other residents that were in OB, and they're just the people. I got along with them. But then looking at more in depth, when I was a second-year resident, my mom was diagnosed with ovarian cancer. And you all know how, horrible ovarian cancer can be. And she passed away at 57 from that disease process. But what I noticed was, while I knew a lot about the disease, I knew a lot about the surgery and the chemo and the whole 9 yards, what I couldn't do, and this was back, I want to say around 2000, somewhere around that time, that I couldn't help my mom feel better. Like, she'd do the chemo and she'd call me and she'd be miserable. Her joints were hurting. And I couldn't even help my own mom just feel better. I was not even worry about cure the disease, but just feel better. And so when she passed away, I just felt like I needed to do more. And so I was reading a book at the time by Andrew Weil called 8 Weeks to Optimum Health. And at that time, back in 1999, he was talking about crazy stuff like fish oil and magnesium and CoQ10, which now we kind of take for granted. But back then I was like, oh my God, I can't believe this. And so it just so happened that the training program was in Tucson and I lived in Tucson. So I was like, well, this is serendipitous. So I finished that 2-year fellowship in 2007 and then decided, because I guess I like to spend money, to do a PhD. And so I did 6 years. Following that, I did a PhD in philosophy where I mainly focused on mind-body techniques and things like that. And that's where I'm at.
Yeah. It's such a fascinating story because you don't see that combination of someone who is conventionally trained in OBGYN and who's a surgeon, but also has that integrative approach, and also in your case has that approach to philosophy and a PhD in that. So it's a really remarkable combination, and I think that's what makes for a great practitioner. So
Thank you.
I think, and you touched on something with your mother that's so important, which is what we try to do, which is not just to see the patient as a case, but to really want to make them feel better, improve their symptoms. And so I think medicine can, especially in the hospital, can sometimes get bogged down to we're just fixing the case as if it's a mechanical issue, whereas we don't take into account the human behind that who's having real life day-to-day struggles. So a very important point there. So I want to dive into hormones, and we're talking more specifically about female hormones today and about estrogen, progesterone. So just as a primer for people who may not be so familiar with those hormones, what are their main functions, and what imbalances do you see generally with them? If you could briefly give people an introduction.
Well, the main hormone that women are acutely aware of is estrogen, and estrogen is basically, in my opinion, that consummate hormone that makes you female. It's responsible for secondary sexual health characteristics like breast development and, things like, what makes you XX female, as it were. Estrogen is responsible for every receptor or cell in the body has a receptor for estrogen. Hair, skin, vaginal health, breast health, bone, obviously, density health, cognition, and how you think and feel. Progesterone is kind of the sister hormone to estrogen in the sense that during your cycle, progesterone is more heavily dominant in the second half of your cycle, that luteal phase, we call it. Women that are low in progesterone can have more symptoms of PMDD or PMS, so they can, irritability and anger and insomnia. So progesterone is responsible for not only having to offset some of the effects of estrogen because it's an estrogen receptor blocker in a sense, but it also upregulates GABA receptors in the brain, so it helps with sleep, it helps calm you down. It's a natural diuretic, so when you retain fluid from estrogen, you can actually lose it again when the progesterone kicks in. And then the other big one that I think is huge, but we don't really talk about with women's health, is testosterone. And
Right.
Testosterone is in every woman, just as estrogen is in every man, but they're just in lower amounts, and they serve a purpose. And for women, testosterone is drive, oomph, zest. It's a mood enhancer, so it can help with depression. It's a 1-2 punch with estrogen to help. Estrogen stops bone loss. Testosterone helps build bone.
Right.
It's kind of like muscle density, which we know nowadays muscle mass is probably one of the greatest predictors of longevity. The more muscle you have, the more healthy you are. And so I think it's really important, and I think it's probably the plague of the our 21st century in the sense that most women have low testosterone, and it's just not addressed.
Yeah, I've been finding that more and more. And so now with the women that I see, especially coming in with energy issues and fatigue, because that's a very common complaint, it's amongst other things so important to check for testosterone. So appreciate you mentioning that. So what are the main imbalances that you see in your practice amongst all the women that you've seen? Are you, especially amongst the younger women, are you seeing more of an estrogen dominant state with lower progesterone levels and lower testosterone levels?
So first of all, a lot of our colleagues, especially in the OBGYN space, are trying to say that hormone imbalances aren't a real thing, they don't exist. And I think when I say it, I wrote a whole book called The Hormone Balance Bible, so obviously I believe that there is a balance to be had. But when I'm talking about, when we say imbalance, I think what we mean is there are certain times in life when imbalance is normal. Puberty, menopause, pregnancy, certain times of the menstrual cycle, things aren't balanced. They're not balanced, and they're not supposed to be. However, when that imbalance becomes a problem for the way that you want to live your life as a female or a woman, then it's one of those things where that's when we need to get involved. That's what I'm talking about with imbalance. So the number one hormone imbalance, I have a quiz that I use. It's 35 questions for people that just, are bored on the internet at midnight. And I thought that the estrogen dominance was going to be number one far and away, but by far, not even close, is testosterone deficiency. And testosterone deficiency, like you said, fatigue around 4 or 5 in the afternoon. If you had a T-shirt and you wanted to tell the world how you felt, it would just say meh. I always say you can get stuff done. You're just not going to do it with style. And then second, I would say, is estrogen dominance. Your estrogen is just simply too high with regards to your progesterone. And then the double whammy, which I think is number 3, is high estrogen, low progesterone, which is even worse than just having high levels of estrogen.
Okay, that really spells it out. So to stay on the testosterone topic a little bit. For the lay people out there, when they check their levels of testosterone, which is a total testosterone and a free testosterone, because our lab values sometimes give us these ranges that don't really coincide with what we think is where they should be, what are you seeing as the aim that you want women to be at for total testosterone and free testosterone?
When I look at somebody that comes in for an imbalance or for somebody that's not feeling well, and we draw blood, you can do urine as well. I'm not a huge fan of salivary testing, but I do blood just because it's covered by insurance.
Yeah.
And you're right, it's a range. So let's say for free testosterone, and the free testosterone is the active testosterone in your body.
Yeah.
So let's say for a free testosterone, the range is 0.2 to 6.4. So that's a massive range. That's a 32-fold range right there. Most women that I will see will come in somewhere below 1.0, and a lot of them come in around 0.4, 0.3. So a doctor could look at that result and say it's normal, because it is. But the way I look at it is this. I always tell patients, okay, so you're normal, so you're in the house, but you're laying on the floor in the basement. So to me, I like to generally shoot for the middle of the house. So a free testosterone of maybe 3.5, somewhere around there. But I also combine that with how the patient feels. So if I put somebody on testosterone who is having issues with fatigue and sex drive and desire and all that stuff, and I put her on testosterone, and at 4 to 6 weeks she comes back and she says she feels great, and her levels are only 2.2 free testosterone, I'm okay with that. I probably wouldn't go up on the dose. I'm kind of like lowest dose possible to get the symptoms to feel better. So that's kind of how I would do it. I look at both the symptoms and the actual numbers. Unfortunately, a lot of women will come in with a testosterone level, but they only get the total. Yep. And the total, it can be helpful, but the free is and it's the same with thyroid. So you can look at TSH, or you can look at a free T3 or a total T3, and the free T3 is obviously what we see with active thyroid. So it's the same concept.
Yeah. And in terms of I know you're using creams mostly with the women that need testosterone replacement. If there are women that may not want to start on testosterone, are there anything else that you try before that in terms of any supplements that can help boost their testosterone levels without using it?
I think for my patient population, if they don't want to go on testosterone, I'll try to, first of all, get them into like doing weights, so resistance training.
Yeah.
I will also try to get them to increase their protein intake, because most women aren't really eating enough protein, and I usually have them shoot for easy 1 gram per pound of body weight. Most women should probably be up around 100 to 150 grams of protein, and they're probably eating 30 or 40. Okay. You can use supplements you can use, there's things out there that are need a little bit more monitoring, like Damiana and rhodiola, and then yohimbine. Yohimbine obviously is a bit of a stimulant, has alkaloids, so that can raise your blood pressure and stuff. So you want to be careful with some of these things. But honestly, I'm also one of those people that thinks that if you want to get from point A to point B quicker, then use the hormone. And I'll have women use the hormone initially, and then also maybe add some of the supplements we've been talking about in the resistance training and the protein. And then over the next 3 to 6 months, maybe back off on the testosterone, because I want women to feel better now, and then we can work long-term getting a plan in place so that they can maybe get off of it.
Yeah, and their buy-in to that is bigger, because if they're feeling better, then their motivation levels are much higher. So
exactly.
Great. Well, I want to shift a little bit to what we were going to talk about, endometriosis, and understanding that as a condition, because we see so many people affected by that. So if you're able to explain a little bit about what endometriosis is, and if we know what causes endometriosis.
If you want to get in trouble, the fastest way to get in trouble is to post about endometriosis on Instagram. It's a very debatable topic, and there are fervent supporters on many different sides of it. So endo is horrible. It's a disease process whereby tissue that resembles the lining of the uterus implants outside the uterus in the pelvis. And so the number one spot being the ovary, back behind the uterus, the colon. It can spread to the lungs or the brain in very rare instances. I've seen it in C-section incision sites. It can be everywhere, and it can cause a lot of pain. And because women are somewhat pushed down by the medical system and minimalized, it can take about 6 to 7 years to actually get proper diagnosis. And the way that we currently can diagnose it, we can be suspicious of it based on history, but you really have to see it. And the best way to see it is with laparoscopy, by putting a camera in. Then the debate that rages right now is you go in and you see endometriosis. Do you remove it? Do you excise it or cut it out? Or do you just ablate it and cauterize it? The thoughts on cautery is that the cauterization doesn't go deep enough, so it's better to have it physically excised. What I do with my patients, though, is once I diagnose endo, and I have doctors in town, other gynecologists that will send me their post-ops, because I focus on hormones post-operatively as well, because it makes sense that if you're estrogen dominant and you don't have enough progesterone, that you can put yourself back in a scenario where you're just growing that more rapidly. I also work on inflammation, and I will use like Zyflamend, which is holy basil, rosemary, turmeric, and I'll also consider in some women using low-dose naltrexone, because that helps increase the endorphin production in the body, which helps with inflammation and pain. And I have a lot of good results with that.
Okay. So when you talk about the controversy around it, is it primarily related to its treatment, or is there controversy around understanding the disease itself?
There's a controversy regarding how it comes about. So there are some folks that the belief used to be what we would call retrograde menstruation, where we thought maybe when you had your period, it was backing up out the fallopian tubes and depositing cells in the pelvis. There's some new theories now that it could be coelomic metaplasia, meaning you're kind of born with it and it just develops over time. We do know there is a big genetic component to this. But the debate basically raises on the fact that we used to say that endometriosis was the tissue lining the uterus. So if you put that on Instagram, inevitably there will be hundreds of women that will come on and correct you and say that it's endometrial-like tissue. It's not actually the same. And we also are starting to wonder if maybe it's not an autoimmune disease. So there's a lot of theories floating around, and some people... David Redwine is an older guy that's been in the endo circles for decades. He's a doctor and a gynecologist, and he's got a lot of fervent followers. Obviously, some of the academics don't agree with him, but so it's like you have different camps. And unfortunately, we're all on the same team. It's just some people are claiming to be right. I kind of think it's like, I'm sort of agnostic. I can't pretend to know exactly why or where or how it got there, but I can do my best to help fix it and then to prevent it from coming back.
Yeah, and I think that's what's necessary for so many of these different camps with different conditions, where people are so fervent on their side, completely thinking that they're right, whereas we just want to have that humility to stay in the middle and say, we're, looking for the best evidence on what we may think it is, whether that's treatment for certain things, whether that's understanding of disease processes. So
I think a lot of these patients too, they haven't been heard and they've been brushed off by medicine for years. So they're angry. And I totally understand that. And I think that the anger in and of itself is justified, because women do tend to get the short end of the stick when it comes to healthcare. But endo is complex. It's not just one thing, and that's the point. It could be hormonal. It could be genetic. It could be inflammation and what you eat. I think nutrition plays a huge role. And so I think it's a multifaceted disease, and I think it needs a multifaceted approach.
Yeah, completely agree. And when you mentioned women being angry, specifically on hormones and how that's been played out for the last 20 years, they have legitimate reason to be angry when
Sure.
it comes to hormones. So there's
Yeah,
so many things with that. So do you find any utility with ultrasound testing before, like if someone isn't willing to do a laparoscopy?
You know, there's a guy in Denver, Jeff Arrington, that does a lot of endo, and he claims that he can see implants in the colorectal area because he's done thousands of cases and he's done a lot of ultrasound. So maybe in his case, yeah, you can. But if it's just somebody like, say, in Austin, and you send them to the local radiology department, ARA, or one of those places, the average ultrasound tech, the average radiologist isn't necessarily going to be able to make out an implant because they're small. However, if you have an endometrioma, which is a endometriosis cyst on the ovary, that is definitely something that they can discern, because the inside, the fluid actually, grossly enough, looks like chocolate milk. And so on an ultrasound, it looks very gray instead of nice and dark black like a clear fluid would look. So that can definitely tip you off. And endometriosis tends to also travel sometimes with its cousin adenomyosis, which is where the lining of the uterus, instead of implanting outside in the pelvis, it grows roots into the muscle wall of the uterus, and that causes super heavy, painful periods. And sometimes you can see that on ultrasound, but endo in and of itself is really hard to see on an ultrasound.
Okay, that's good to know. So really definitively laparoscopic intervention would need to take place. Okay. And we touched on I was going to ask about the conventional versus integrative approaches to endometriosis, but you touched on that in that you're looking at what the underlying cause is, inflammation and dietary approaches. And so presumably a lot of the conventional gynecologists are not necessarily doing that when it comes to endo.
Traditional gynecologists, first and foremost, probably would put you on a birth control pill. And that's why you get this delayed diagnosis, because when you're 16 or 17 and you come in with this complaint of pain, you automatically get put on a birth control pill. And then, you're on pills for 10 years, and then you come off the pill, you still have pain. Other docs will maybe do surgery right away, and they'll find the endo and they'll remove it, but then they also put you on birth control pills. So, the birth control pill is not to give them a bad rap, because they can help, but the reality is they're not fixing the disease, they're just covering it up. So you can live your life and you can be more productive, but we're not actually fixing the problem.
Yeah, and that's what we are focused on when it comes to treating our patients. And so I want to go back to something you mentioned earlier. You had mentioned that you weren't a big fan of saliva testing. Are you able to elaborate on that? And if you have a preferred method of hormone testing, blood or urine?
Again, I know a lot of my colleagues in the integrative space do saliva testing. The reason that I'm not a fan of it, one, right now, my practice is set up as an insurance-based practice. Now, I'm finding out that that's really hard to do. Solo practitioner. It's hard to pay your bills, and so I may be switching in the near future. But that being said, saliva, if you look at the data, there's a lot of conflicting data that some people will secrete different in their saliva than the next person. And so and then if you had anything in your mouth and you didn't do the test the right way, you can get varying results. They've done some studies that have shown, like you could have high progesterone on a saliva, but blood, it's actually low. So it's not reproducible, and in my opinion, just not reliable. So blood, the reason I use blood usually first is because I take insurance and it's covered by insurance. So I can order through LabCorp or Quest or whatever. Keeping in mind that blood is very accurate because it's what's in your blood. However, it's limiting because it's only going to tell me your hormones for the 10 seconds the needle's in your arm. Yeah. So it's more of a Polaroid, if you will. Right. I do use the Dutch panel, which is a 24-hour urine test, which is fairly accurate. It also can check cortisol, which I can't do with blood. And it will check your hormone metabolites, your estrogen and things like that, so I can see how you process things. It checks organic acids, vitamins, and melatonin. So it does give you a lot of extra information. It's a 24-hour test. It doesn't get covered by insurance. Ranges anywhere from, I've seen, $350 to $600, depending on where you order it. And the only real downside is it doesn't check thyroid, and it doesn't check vitamin D. And it takes about 3 weeks to get the results back, whereas blood is, within a few days usually.
Yeah. Yeah, no, that's very important because there's a lot of controversy in that, where some people are for saliva testing, not for urine testing, and the other way around. So I'm glad. And I think
if I had to do saliva testing, what I tell people is salivary testing may be good, but I think you have to do it in the sense of you can't, one test for me, you'd have to do multiple tests. And if you see trends with saliva, like every time we do your saliva, your estrogen's low. Okay, well, that's probably reproducible.
Sure.
With blood, it's super accurate, but it's just for Tuesday. It's not like I can't tell you are 10 o'clock on Tuesday. So with blood, you have to be savvy in the sense that you got to know where they were in their cycle, what time of day they took the blood test, because if they're taking hormones, like let's say your hormone's low, like your progesterone's low, but you did the blood at 4 o'clock p.m. and you take your progesterone at 10 p.m., well, you've been without your hormone for 18 hours. So it's probably, so you just have to keep that in mind as the practitioner when you draw blood.
Yeah, that's a very good point. And to that point, we were talking about testosterone levels earlier, but also when it comes to estrogen and progesterone, are you using a particular day in the cycle? I know for certainly for progesterone, day 18 to 21 is when it peaks, and so that's the best time you want to test progesterone. But similarly, are you having women do it on a certain day of the cycle?
In an ideal world, testing around day 21 would be great. I have women that usually come see me really frustrated, or they've seen a bunch of other people and they don't want to necessarily wait 3 weeks to do their blood tests. So what I do is I'll just test blood whenever. Like I said, I know I want to know where they were in their cycle, what time of day the blood was drawn. And then I think, if you've done it enough, you know what you're talking about just based on experience and symptoms. And then also what I do is, so I'll come up with a plan based on what I see. But then in about 4 to 6 weeks, I'll call the patient. And if she says, you know what, I feel like $1 million, okay, well, we'll just stay on this for maybe 6 months. And then we'll draw blood again. If she's like, I feel better, but I'm not exactly where I want to be, then I'll probably do another blood draw and, try to triangulate dosages and really fine-tune things.
Great. And so when we do have levels, mainly from the blood, then we want to use ideally bioidentical hormones when replacing hormones and balancing them. So just for the layperson out there, are you able to just give a primer on bioidentical hormones and what ones you use?
So it's a big marketing thing right now. Most of the hormones on the market nowadays are bioidentical. It used to be when I was a resident 25 years ago, it was, all we had was Premarin and Provera. And those were highly synthetic, made from horse urine and things like that. And then slowly over time, when we talk about bioidenticals, when I talk about it, I usually mean compounded pharmacies. Like I'm having it made here in Austin. But there are big pharmaceutical companies now that make bioidentical hormones like Estrace, Vivel, and there's patches that are now bioidentical. Combi patch is an estrogen progesterone patch, but it's the progesterone part is synthetic. The estrogen part is bioidentical. So there's a topical pharmaceutical estradiol gels now, estrogel. So they're widely available. The downside to pharmaceutically doing it at, like, say, Walgreens or Walmart, usually those medications aren't covered by insurance because the insurance companies don't think that they're important for life. So they're going to cost you $40 as a copay anyways. And bioidentical compounded hormones, I can have those made at a pharmacy here in town. Say, I can put estrogen, progesterone, testosterone, DHEA, anything in there, and it's always $45. So it doesn't matter how much I put in there, what I put in there. It doesn't change the price. Pretty price comparable And micronized progesterone first came out about 15 years ago. It was called Prometrium. Now it's generic. I had a lady call me the other day. She's like, "Oh, you didn't give me bioidentical progesterone. You gave me micronized progesterone." Well, that is bioidentical. Right. So, and bioidentical is a little bit of a sales pitch too. I think that a lot of alternative folks glom onto the word bioidentical, but the reality is probably 90% of what's on the market right now is bioidentical. It's usually made from either yam or soy, usually a plant-based product. And, there are still some women out there on methyl testosterone, which is awful. Occasionally I'll still see a Premarin patient come through, which I don't see that anymore at all. And birth control pills are synthetic. So birth control pills usually will contain ethinyl estradiol, which is a synthetic estrogen. It's not bioidentical. And the reason that we talk about bioidentical is the thought process is that that estrogen looks exactly like your body's estrogen, so it will fit the lock perfectly. Whereas ethinyl estradiol that's in a birth control pill will stimulate that receptor, but in most instances it's an endocrine disruptor, so it will hit that receptor so hard that you get side effects. And so I think birth control pills, they're about 7 to 10 times stronger than like a bioidentical estrogen that I would put someone on for menopause.
Yeah, it's so important, and I'm glad that you laid that out, because a lot of people have confusion, and it's important that they understand when they're being prescribed hormones, what type of hormones they are, and what the best hormones out there are as well. So I appreciate that.
Sure.
So this has been such an important conversation. There's so many women that you see, that I see, that are struggling with these hormone-related symptoms, with possible endometriosis, and so more conversations like these are needed, and more awareness is needed in the medical community, but also in the wider community. So I appreciate taking the time to speak to me.
Of course.